fine with me. It's funny that our clocks are not all synced to being online, but that is how it is. So yes, absolutely. Okay.
So I would say hello and welcome to everyone this afternoon. My name's Kathy Waite and I volunteer with CARP in Regina. In a moment, we're going to be hearing from Kathleen Spat, who's the president of CARP in Regina, and also today's guest speaker, Gary Lamb from Sanofi. I think this will probably go about an hour, but if we run over, because there's lots of questions, that's fine. At the bottom of your screen, you'll see there's chat and there's also Q&A options. If you could please type your questions into the Q&A, not into the chat, then I'll collect them up and we'll address them at the end of the presentation. In the chat, if you'd like to say hello and add in your name, perhaps where you're from. Some people actually write us brief notes and say why they're here or how they heard about the session or why they're interested. So that's always kind of entertaining to see who's around. I believe this is being recorded and we hope to have the link to be shared later on through Facebook. So that's the domestics for now, and I'll hand over to Kathleen.
Okay, thank you, Kathy. For those who are unfamiliar with CARP, CARP is Canada's largest advocacy organization for older adults, with over 320,000 members across the country. As a nonprofit, nonpartisan association, we advocate to uphold the rights and improve the lives of Canadians as we age. Our chapter is located in Regina, but as the only chapter in Saskatchewan, we advocate on behalf of all older adults in Saskatchewan. So I'd like to welcome you to the third in a series of town halls which we've been conducting, which have been focusing on the critical issues of seniors advocate, a long-term care reform, and today vaccinations for older adults. Our speaker today is Gary Lamb, and I would like to just tell you a little bit about him. Gary is the medical science liaison with Sanofi Pasteur Canada. He joined Sanofi in 2016 and has held multiple roles in the medical affairs department. Gary holds a Doctor of Pharmacy degree from the University of Toronto, and he continues to practice as a pharmacist in the community setting. Currently, he is also pursuing a master's degree, a master's in science, in clinical epidemiology and health economics at the University of Toronto. I would like to welcome Gary Lamb. Thank you.
Thank you so much, Kathleen, for the awesome introduction, and thank you, CARP, for having me here for this presentation. I'm just going to share my screen, so just one moment. Okay, so can you guys see the slides?
Looks good.
Okay. That's perfect. Okay, so I also noticed there has already been a question in the Q&A, but hopefully, this presentation, as we move along, will answer that question for you. And if not, I'll elaborate a little more near the end of the presentation. So, of course, good afternoon, everyone. Thank you again for this opportunity to present on the impact of vaccine-preventable diseases, focusing on older adults aged 65 years of age and older. So the three diseases I'll be covering today will include seasonal influenza, pneumococcal diseases, and finally shingles, or also known as herpes zoster. So here in Canada and many places around the world, we do have an aging population, and so it's expected in around 20 years, the number of older adults is expected to double. And to put this into perspective, the proportion of older adults has already exceeded those children 14 years of age and under back in 2016, and it continues down that trend. Specifically in Saskatchewan, it's also around, older adults do account for around 15 to 16% of the population as well. So even though it should have been clear before, since we have this aging population, COVID-19 has really reminded Canadians how important it is to protect older adults across the country, because it's become very clear as well that the current support systems in place just aren't sufficient. So as we know, COVID-19 has had enormous impact on our community, our healthcare system, and also the Canadian economy. But in particular, it has had a disproportionate impact on our older adults. And this is a reoccurring theme that you'll see across all these infectious diseases that I'll be speaking to today. So despite only accounting for 28% of all COVID-19 infections, older adults accounted for 70% of all the COVID-19 related hospitalizations, 60% of all the ICU admissions, and 97% of those COVID-19 related deaths. And these numbers, if you remember them, the 70% of hospitalizations, for example, and 97% of deaths, these are quite similar to what you'll see when it comes to influenza, for example, as well. So we, again, really do see this disproportionate effect on older adults. So although influenza vaccines don't prevent COVID-19, vaccine preventable diseases are currently one of the variables that's within our control that can reduce the impact on our population. So if we prevent, for example, influenza, pneumonia, and also shingles, what's important is that when you reduce these infectious diseases, not only does it prevent confusion with possible COVID-19 infection, but it also mitigates, how likely you are to go and get tested. If you do happen to get sick, it is very important to get tested because not only are you protecting yourself, you'll be protecting others as well. But all of these infections can cause fever. And so, if you happen to get it and then you get a little worried and in the end, you're going to have to get tested, even if you don't have COVID-19, what you're honestly doing at the same time though, is you are putting yourself at risk because when you go into test centers, now you're exposing yourself to a lot of these possible infections that you may not have. So year after year, influenza vaccine coverage rates have been quite steady. So it's increasing little by little. We can see in all adults, it's only at 42%. If we look at older adults, it's definitely better at 70%. But what's important here is that we're quite far from the national target. And COVID-19 has really reminded Canadians just how severe respiratory infectious diseases can be. So hopefully during this time, people again realize just how important it is to stay healthy, and vaccines are one of the ways that can really support that, including like a healthy diet, exercise, and all of that. So first, seasonal influenza. So in Canada, it generally occurs every year beginning in the late fall and early winter, and it'll end around in the early spring. And it's estimated that around 5 to 20% of the population becomes infected with influenza each year. So there's quite a bit of, I guess, variance here because no two influenza seasons are the same. Sometimes we have very severe influenza seasons, and sometimes it can be a little more mild. But rates of influenza infection are highest when we talk about young children, older adults, and those with underlying medical conditions. So influenza is a highly contagious respiratory illness. It takes around 1 to 4 days before the symptoms appear. And then, if you did get sick and get symptoms, it takes around 2 to 7 days for the symptoms to go away. So on average, people do get better in around 10 days, but for those with more chronic conditions, more frail, maybe a little less healthy as a whole, it can take up to 3 weeks to fully recover. When it comes to transmission of influenza, those that are infected and contagious can actually spread influenza up to 2 days before symptom presentation and up to 7 days after for a total of 9 days. And what's really important to take away from this is that you can start spreading influenza even before you have symptoms such as the fever, the coughing, the sneezing. And that's also why it's so infectious, because people can continue to go around, do their daily activities and not realize they could be spreading influenza. And if that sounds familiar, it's because that's the same with COVID-19, where it also has this incubation period where you may not have symptoms yet you're out there spreading the disease without knowing it. Now, how it's spread, there's two ways. One, we call it direct transmission. So when someone's sick is coughing or sneezing, they release these droplets in the air and it carries the virus. And if you come into contact directly with one of these viruses and you breathe it in or it gets into your eye or your mouth, you can get sick with influenza. Another way to get into contact with the virus, we say it's indirect. And that's because when we talk about the influenza virus, if people are coughing and sneezing, they contaminate, surfaces such as tables. If they touch their hands or cough into their hands, they touch doorknobs, and the virus can actually survive on these surfaces for up to 48 hours. So that's 2 whole days. So this really stresses the importance of both hand hygiene, which is extremely critical when we talk about infectious diseases, and also why you should practice good, cough etiquette and also sneezing etiquette. So don't sneeze in your hand or into tissue. It's best to sneeze, for example, into your arm because that just prevents the large aerosolization of those droplets. And of course, if you happen to sneeze or cough into your arm or your hands, make sure you, of course, wash your hands after that as well. So in my own practice as a pharmacist, not surprisingly, I notice a lot of people are quite confused when it comes to the difference between the common cold and influenza, for example. And it's not surprising because there's quite a bit of overlap when we talk about the symptoms such as the coughing, the sneezing, the runny nose. But really, it's the more severe and systemic features that characterize influenza. So that would be the fever, the aches and pains, and the fatigue that really characterize influenza. And there's also this potential for complications. So often people talk about secondary bacterial infections such as pneumonia. So what I want you to remember is that, not only is influenza more severe, but it very commonly causes these potential complications that are not only common, but also very, very severe. And now with the ongoing pandemic thrown into the mix, there's that confusion with COVID-19 as well, because it does also have a very wide spectrum of severity. So some people have very, very mild symptoms, whereas other people will end up getting very, very severe symptoms and they'll end up in the hospital or in the ICU. So some symptoms of COVID-19, for example, would be fever, fatigue, and cough, which are common. So you can see it's quite similar to influenza in that regard, but it can also cause symptoms that you may not be thinking about, such as some people get an upset stomach and diarrhea. And one that's probably more unique to COVID-19 would be that sometimes it can cause shortness of breath, whereas for influenza, that's quite rare. So influenza, what we see year to year is that it continues to be a serious public health concern. Each year causes approximately 3.5 million symptomatic infections. So that's around 10% of the population on average. And it also has a very large impact on our economy and our public health system. So it causes approximately 2.3 million work absentees, 900,000 physician office visits, 175,000 emergency room visits, 12,200 hospital admissions, and approximately 3,500 deaths. And what's important to take away from here, though, is that some of these are in fact vaccine preventable, because as I showed you earlier, our vaccine coverage rates here in Canada are extremely low, definitely better in older adults, but really there's quite a bit of work to do there. And if we can increase these vaccine coverage rates, it would definitely reduce this burden that we're seeing here overall on a year-to-year basis. So in terms of the non-pharmaceuticals, so what you can do outside of using medications or the vaccines, these are again very, very important. One is to get rest, because of course that's going to help you heal and get better. And two is to stay hydrated. Very, very important. It's definitely can lead to some very, very severe outcomes and hospitalizations. If you're sick and you're not eating and you're not drinking, you can very quickly get dehydrated, especially if it's causing other symptoms. And finally, infection control, which I mentioned earlier, is just critical when it comes to, again, washing your hands, having good cough etiquette. And if you are sick, whatever, even if it's the cold, especially if it's, of course, influenza or COVID-19, you really do want to stay at home and you don't want to spread the disease, especially to those at high risk. And again, when we speak to infection control and prevention of the spread of disease, a lot of other things have come into play now with the ongoing pandemic. So there's also masking now whenever you go out, and that really is to protect others around you, because you're creating a barrier for your own respiratory droplets. And there's also the social distancing. And again, you want to prevent the spread to those at highest risk. So that includes older adults, the young children. You want to avoid hospitals, and then also nursing homes and long-term care facilities where you have, a clustering of people at high risk. So now let's focus in on influenza in older adults. So the reality with influenza is anyone can get it. But what we do see year to year is that older adults do experience the majority of the severe outcomes. So they experience the majority of the hospitalizations and the majority of the deaths related to influenza. So in Canada as a whole, even though adults only represent 15% of the Canadian population, and now we're up to around 18% of the Canadian population, they do account for around 70% of influenza hospitalizations and up to 91% of influenza-related deaths. And that definitely varies from year to year, but when there are more severe influenza seasons, it's definitely over 50%, so 50 to 70% for hospitalizations. But regardless of the type of influenza season, older adults always account for the majority of influenza-related deaths, so anywhere from 60 to 91% of those influenza-related deaths. Now, as I mentioned earlier, when we talk about the potential complications of influenza, not only are they common and quite severe, but often people think about the direct effect on the lungs. So that would be if you have asthma or COPD, which is chronic obstructive pulmonary disease. If you get influenza, it can definitely worsen those. And if it gets bad enough and you get other infections, you may get sent to the hospital. And the more common one people think of is if you get influenza, it can lead to a bacterial infection from pneumonia, which is, again, not only common, but also very, very severe. But now there's also a large growing body of evidence looking at the impact on other organ systems. So these are things that people may not be thinking about. So influenza has been shown to trigger things such as a heart attack. Some have shown it can have a link to strokes. It can also worsen renal disease. So there's this impact on other organ systems, because when you get influenza, it triggers this underlying inflammation. And this inflammation is what's triggering all these other really bad events. And what I'll add to this is it's not just influenza. It's something that is being studied and seen from respiratory diseases as a whole. So definitely this is something you see when we're talking about pneumonia as well, where you're seeing this link to heart attacks, for example. For COVID-19, it wouldn't be surprising if you see that link as well, because it's also being studied and it's for sure causing very significant and severe inflammation, which is why people are ending up in the hospital and also in the ICU. So just to add to that, this is a study that came out of Ontario. So this is Canadian, I guess, data. So what they were looking at the Ontario's the Ontario healthcare records. So what they saw was that in adults, so 18 years of age and older, 7 days after getting an influenza infection, they noticed that there was this association where they were at 6 times higher risk of an acute myocardial infarction. So this is a heart attack. And if we look specifically at older adults in the study, that risk of a heart attack went up to 7 times. So again, this is again showing that there is a risk or this link between influenza illness and the increased risk of a heart attack. And very common when we speak to, honestly, just adults, so beginning around the age of 50, let alone the age of 65 years of age and older, but people tend to have more than one chronic condition. So it's not just that someone might have diabetes, for example, they may also have high blood pressure, and so on. And so in this study, they did look specifically at older adults. And what they were looking at was this stacking effect. So if the older adults in the study had a chronic heart disease, their risk of influenza attributed death, so their risk of influenza death was 5 times greater. Now, if they had a chronic lung disease, so for example, asthma or COPD, that risk went up to 12 times. And the stacking effect here we can see if they had both, it went up to 20 times. So again, this really speaks to how important it is, especially if you have underlying chronic conditions, to get vaccinated. And it's not just for influenza, I'll say this again as well. But if you look at pneumonia, even COVID-19, you'll see very similar risk factors where the vaccine or the measures for prevention will include people over the age of 65. You'll see young children as well, and also those with chronic lung diseases, chronic heart diseases, and people with metabolic diseases such as diabetes. So beyond these hospitalizations and deaths, there's also a very significant impact on their quality of life. And that's, of course, very, very important because this is what's going to keep you healthy and at home and functioning well. So when we talk about aging as a whole already, there's changes to the body. So you can have effects on your mobility, you have less muscle mass, there's changes in the skin barrier. So all these things naturally put you also at a higher risk for infection. But what studies have been showing is that if someone were to get influenza and they're hospitalized for it, around 15% of older adults that end up hospitalized with influenza can experience something called catastrophic disability. And that's the loss of 3 or more activities of daily living. So one activity of daily living, for example, is simply getting dressed, eating, going to the washroom. So as you can imagine, just losing one of these can have a very significant impact on your quality of life, let alone losing 3 or more. And really one of the goals of older adults really is to stay healthy and stay at home with their family. They don't want to end up in a nursing home, for example. So this is another reason why it's very important to prevent influenza. So not surprisingly, influenza vaccines are recommended by both the World Health Organization and also the Public Health Agency of Canada as the most effective way to prevent influenza and its complications. So again, those complications include hospitalizations and other infections. And often there's quite a bit of confusion also when it comes to how effective the vaccine is. So this shows over 10 years of influenza vaccine effectiveness here in Canada. So you can see it's not a perfect vaccine and it does vary from year to year. And on average, people will say that the vaccine is around 50 to 70% effective. But one of the issues that we run into is with aging. Naturally, there's also the aging of the immune system, which I'll speak to in an upcoming slide. But what that causes is a reduction or a potential reduction in how effective the vaccine is. So in this study, you can see in the top black line that in younger healthy adults, again, the influenza vaccine is quite effective. And here it shows is around 60 to 70% effective at preventing influenza. But in those same years, when they looked at older adults, that vaccine effectiveness dropped to around 30 to 50%. So again, you have this potential gap in vaccine effectiveness. And one of the reasons for that is something called immunosenescence. And this doesn't just have an impact on influenza and influenza vaccines. This will have an impact, as you'll see later, also when we're talking about pneumonia vaccines and also the shingles vaccine as well. But what immunosenescence is, it's the natural and progressive weakening of the immune system over time. So some people think of it as the aging of the immune system. And so if you have a weaker immune system, that means you're at a high risk of getting any sort of infection naturally because your body relies on your immune system to protect you. And two, when you get vaccines, the vaccines are using your immune system to create these proteins called antibodies. And these antibodies are what's going to protect you from these infectious diseases. So these vaccines are still very effective, but they're not as effective as they would be compared to younger healthy adults, for example, because again, the immune system is a little weaker. And so at the very bottom here, you can see this is a statement that comes from the National Advisory Committee on Immunization. It's that in older adults, influenza vaccine effectiveness is roughly half of that compared to younger healthy adults. So when it comes to influenza recommendations across Canada, it's recommended that all individuals 6 months of age and older without any contraindications to the vaccine should get the influenza vaccine. And there's a particular focus on those at high risk of complications and hospitalizations. So we have all pregnant women, adults and children with chronic health conditions. So we can see here again, there's cardiovascular ones, there's metabolic ones such as diabetes, and another important group would be those with immunocompromising conditions. Next, we have people of any age who are residents of nursing homes and other chronic care facilities. And that's because you have this environment that creates, crowding of people with typically high-risk conditions. We also see age in itself is a high-risk factor. So we have older adults, age 65 years of age and under and over. And also we have all children, so 6 to 59 months of age. And for them, it's because they have a very naive immune system. So they haven't been exposed to much yet. And so they don't have any sort of protection yet. We also have Indigenous peoples, which again, they have a limited access to healthcare resources. And also they may be living in more crowded conditions as well. We have people capable of transmitting influenza to those at high risk. So all healthcare individuals, that's very, very critical. And we have people who provide essential community services. And that's because of how many people they come into contact with on a regular basis. So coming to the Canadian national recommendations, specifically in older adults, we can see here that they do recommend that the high-dose influenza vaccine should be used over the standard dose influenza vaccine because of two reasons. One is the higher burden of influenza A H3N2. I'm not going to go into too much details, but when you get influenza vaccines, there's some that have 3 different strains in it, some that have 4. Whichever one you get, they're both going to cover this influenza A H3N2 strain that they're talking about in these recommendations. But the high-dose influenza vaccine would have a higher dose, so you'd get more protection against the influenza A H3N2 strain. And also there's good evidence that the high-dose influenza vaccine does provide more protection. So looking at the Saskatchewan Universal Influenza Program, here you can see that across the board, they do have a standard dose quadrivalent vaccine that's available for everyone. Besides that, they do also have the high dose influenza vaccine, which is a trivalent, but it's only available for residents of a long-term care facility or those that are part of a personal care home. So as the name suggests, the high-dose influenza vaccine contains a higher dose, so it contains 4 times the antigen content. So compared to a standard dose influenza vaccine that has 15 micrograms of each of the strains, the high-dose vaccine has 4 times the dose, so it has 60 micrograms of each of the strains included inside the vaccine. And it's designed specifically for older adults to create the more robust immune response to protect them against influenza. And in the study, they found that the high-dose influenza vaccine was superior. So it was 24% more efficacious. So this is 24% better than the standard dose comparator vaccine in the study. And another important note was that this 24% increase in the efficacy was against any strain or virus subtype of influenza, because when we talk about influenza, usually you're talking about a population of viruses, not just not just 3 or 4 different viruses. So that's another key takeaway, that it's against any virus type or subtype. If you do get the high-dose influenza vaccine, or if you're looking for it, what you should expect is, in terms of the safety, when we talk about the systemic side effects, so this would be the headache, if there's any mild grade fever, muscle aches. It was trending to be higher for the high-dose influenza vaccine, but looking at them statistically, there was no difference between the high-dose vaccine and the standard dose vaccine in the study. But when we talk about the local injection site reactions, so any pain, any redness, and any swelling that you experience where you receive the injection, there will be more pain, more redness, and more swelling if you get the high-dose influenza vaccine. But what's important to keep in mind was that these were mild and resolved within 3 days. Looking at the availability of high-dose influenza vaccine across Canada, in all provinces and territories across Canada, because of COVID-19, the Public Health Agency of Canada did step in this year and provide federal coverage across all of Canada, only for long-term care facilities. Some provinces do have a bit of an expanded program. For example, in Manitoba, they do provide a little more coverage outside of long-term care facilities. But overall, it's only Ontario that has a complete program for all adults 65 years of age and older. Now I'm going to move on to pneumococcal disease. And often when we speak to pneumococcal disease, at least in my own profession, since I've heavily focused on respiratory diseases such as influenza, but pneumonia in particular is one we often refer to as a partner in crime. And as I mentioned earlier, pneumonia is not only common, but also very, very severe. And what I want you to remember is that pneumonia is considered an opportunistic infection. And I'll go into a little more details in the very next slide, but what happens is, if you were to get influenza or even COVID-19, for example, is it's going to weaken your immune system, because your immune system is going to be busy fighting off another infectious disease. And it also, these infectious diseases of the lungs can also cause damage to your lung tissues. And that creates the opportunity for something like pneumonia to take over as well. And that's where you get this second infection, which will create the community-acquired pneumonia. And so looking back at the pandemic, the Spanish flu pandemic of 1918, which caused a very significant proportion of the entire world to get influenza. But a lot of the deaths were related to these secondary bacterial infections caused by pneumonia. And over on the right here, there's also this chart that shows what are the most common co-infections with influenza. And the one that's on the very left side, the most, again, is caused by pneumonia. So pneumococcal disease is caused by a bacteria, Streptococcus pneumoniae. So instead of a virus like influenza, this is a bacteria, and there's 92 serotypes recognized around the world. There's really 15 ones that people are really worried about that cause the majority of the disease. And this, I know these just sound like numbers, but when we talk about the vaccine later, you'll hear there's one vaccine that has 13 different serotypes and one vaccine has 23 different serotypes. Those are having formulated to cover some of these serotypes that have caused more disease. So as I mentioned earlier, it is an opportunistic infection that resides in the upper respiratory tract. So you think of in the upper airways, such as the nose and the mouth as well. And in a lot of healthy individuals, you may come into contact with pneumonia and your body will just clear it. And then when we look at young children, typically they are often colonized with Streptococcus pneumoniae. And that's really where, if you have grandchildren, you can really come into contact with this pathogen. And if anything happens, so for example, you happen to get influenza or another infection, it can create, this opportunity for pneumonia to infect other parts of your body and create very, very severe disease. So the incubation for strep pneumonia is it's not too clear, but if you do get infection and it does create disease, it can be as short as 1 to 3 days, where you'll get very sudden fever and chills. So that's not too specific, but if it's a lung disease, for example, and it's community-acquired pneumonia, you'd end up getting also the cough, and you can also get chest pains. In terms of transmission of disease, like influenza, can also be direct. So if someone is carrying disease and they're sick and they're coughing and sneezing and they create those respiratory droplets, again, if you come into contact with someone who's sick and you happen to breathe in those respiratory droplets, you can also you can also become a carrier, or if you can get sick with it. And also you can come into indirect contact as well. So again, if someone's coughing or sneezes and it gets onto a surface and you happen to pick that up through the contaminated surface as well. And really when we speak to, what kind of diseases pneumonia can cause, there's two things you can focus on. One is invasive pneumococcal disease, which we'll go into a little more detail as well. So these tend to be way more severe, but they're less common. So this would be bacteremia, for example. So this is when you have pneumonia getting into your bloodstream, for example, and it shouldn't be there. You shouldn't have a infectious disease floating around in your blood. Another one would be meningitis. So this is if the pneumonia were to get into the central nervous system, and what that's going to cause, it can cause this inflammation of some of the lining around the brain, and that has also some very, very severe outcomes. And it can also cause non-invasive disease. So that would be something like community-acquired pneumonia, which is quite common again in older adults. So this slide very briefly speaks to that disease severity. As I mentioned, when we talk about those invasive pneumococcal diseases, they're again very, very severe. So that's why they're over on the left-hand side. But when we talk about how frequent they are, it's definitely, they're quite rare. So that's why on the bottom for the prevalence it says low. And as you move to the right, where the prevalence, so you have more frequency, that's where you'll see the non-invasive pneumococcal diseases such as pneumonia or middle ear infections that are less severe. But when we're talking about pneumonia, it's still very, very severe. And to put it into perspective, over on the right in this slide, you can see when we're talking about bacteremia, the case fatality rate overall is around 20%, which is incredibly high. And it can be as high as 60% when we're talking about older adults. Also, when we talk about meningitis, it's around 8% among children, and it can be as high as 22% in adults. But when we talk about meningitis, it's not just this case fatality rate that we're worried about, because it can cause inflammation around the brain. It can cause a lot of long-term consequences that can lead to disability in the long term. And finally, there's pneumonia or community-acquired pneumonia. It's around 5 to 7%. So again, very, very high, and higher in older adults. And in Canada, invasive pneumococcal disease is the most common among the very young children and adults 65 years of age and older. So again, you can see that parallel to influenza. So what are the vaccines that are available for pneumococcal disease in adults 65 years of age and older? I know it can get a little confusing, so I tried to simplify it to the best of my ability. So on the top, there's a pneumococcal polysaccharide vaccine. So I've highlighted the polysaccharide. If you see an abbreviated version, you'll see new P23. So the 23 is talking about the 23 different serotype it's covering for. And what I want you to take away from this is that the evidence supporting the use of this vaccine is more so for the prevention of invasive pneumococcal disease. So it has around a 60% efficacy. Whereas if you're talking about something like community-acquired pneumonia, that, I guess the data around that it's not too clear how effective it is. So it's said to be inconclusive. So I want you to think of this first vaccine as really the one to prevent invasive pneumococcal disease. And if you are to use this vaccine, preferentially, you're going to use this after the vaccine I have shown in the bill, which is the conjugate vaccine. So if you do get the conjugate vaccine, you have to wait 8 weeks before you get this polysaccharide vaccine. Some people, because they're at higher risk for this invasive pneumococcal disease when they are younger, may have already received the vaccine. So if that's the case and you happen to receive this polysaccharide vaccine when you're under the age of 65, you have to wait another 5 years before you receive it when you're 65 years of age and older. The next is this pneumococcal conjugate vaccine, and it contains 13 different serotypes. And what I've highlighted here is that this is the one that does have data supporting its protection against community-acquired pneumonia. It also has evidence of protection against invasive pneumococcal disease for the included serotypes. But just to differentiate the two to make it a little easier, you can think of this one as the one that will protect you against pneumonia with around a 46% efficacy. So when it comes to this vaccine, it's preferred if you've never received any pneumococcal vaccine to get this one first, and then you wait the 8 weeks before you get the polysaccharide vaccine. Now, if it so happened that you received the polysaccharide vaccine already and you received it first, what you're going to have to do is you have to wait 1 year before you get the conjugate vaccine. And next we have herpes zoster or shingles. So shingles is caused by the reactivation of chickenpox. So if you've had chickenpox when you were younger, what happens is the virus can kind of stay dormant inside some of your nerve cells, and it's also an opportunistic infection. So what happens is if your immune system gets a little weaker, and it could be things due to another infection or even something as common as stress, that can trigger the reactivation of the virus, and it'll lead to shingles, which is a painful and itchy rash that can last from 2 to 4 weeks. And you'll see it'll come in a cluster because when you have this reactivation, it will happen in a nerve cluster. And in each year, it affects around 130,000 Canadians, but most commonly, it's affecting adults 50 years of age and older. So in a Canadian's lifetime, around 1 in 3 Canadians will develop shingles. And by the age of 85, approximately 50% of adults will have had shingles already. And really, when it comes to shingles, already the rash in itself will be very painful and itchy and also cause blisters. But we're also very, very concerned about these complications that can be very serious and long lasting, especially if you have shingles develop on a nerve cluster that involves the face. So if you ever develop any signs of shingles on the head, that's a medical emergency, because if it is the nerve cluster in the eye, for example, it can lead to vision loss. And one of the main concerns when people get shingles is something called post-herpetic neuralgia. So this is chronic nerve pain that lasts for over 90 days, and this can go on to several years. And it's estimated around 10 to 18% of people who get shingles will get this chronic nerve pain. And not only does it have a very significant impact on their quality of life, but there's also limited treatment options. So even though when we talk about shingles, there isn't this very high risk of death like you'll see with influenza and pneumonia, for example, but it can have this lasting chronic pain that can have a very serious impact on your quality of life. So what are the risk factors for herpes zosters or shingles? So anyone who has had chickenpox is at risk of getting shingles, but you might wonder also, what if I've never had chickenpox as a child? Well, the reality is just like with maybe not the best example, but COVID-19, where you have this spectrum of disease. So some people can be very, very mild, some people where it can be very, very severe. When we're talking about chickenpox as well, likely you were infected at one point, but you may not have had very severe full body rashes and the itching that typically we see with chickenpox. So you're still at a risk for shingles. And the most important risk factor here I have highlighted is age. So again, almost or over, so 2/3 of the cases are in adults 50 years of age and older. And the most frequent cases are in older adults, so 65 years of age and older, and people with immune compromising conditions. And very similar to influenza as well, this risk may be explained by the waning of the immune system over time. So again, when the immune system weakens, and if this virus is hiding and staying dormant in one of the nerve cells, it can reactivate when that immune system gets weaker and weaker. And as people get older as well, not only are they at a higher risk for shingles, but how severe the illness is and how likely they will get complications and how severe those complications will be also increases very significantly with age, with up to 10% of older adults requiring hospitalizations if they get shingles. So for the available vaccines, there's two and currently available in the Canadian market, but the recommendations by the National Advisory Committee on Immunization are very clear, and they have a significant preference for the recombinant zoster virus vaccine. So they say it should be offered to all individuals 50 years of age and older without any contraindications. So that recombinant vaccine is called Shingrix, and this vaccine is 2 doses. It's also intramuscular, and it needs to be spaced for by 2 to 6 months apart. And it has an extremely high efficacy of over 90%, and also has very high efficacy, not just at preventing shingles, but also the post-herpetic neuralgia. So that's the chronic nerve pain. And if it makes it easier as well, they also recommend that, if you don't want to space it by just 2 to 6 months, you can also space it by a year. So if you were to get it together, you could get it with the influenza vaccine, for example. So you wait 1 whole year. When you get the influenza vaccine again, you can get the second dose of the recombinant zoster virus vaccine. And even if you received the live zoster virus, so the other vaccine shown below, that's Zostavax 2, it's still recommended to get this new recombinant vaccine, but you'll have to wait 1 year. Also, as I mentioned in the previous slide, even if you don't recall a history of having chickenpox, it's still recommended. And if you have, if you happen to have gotten shingles within the last year, you should wait for a year to pass before you get this recombinant vaccine. Now, for the other vaccine, this live zoster virus, so this is Zostavax 2, it's 1 subcutaneous dose, but you can see here there's significantly lower efficacy, only around 51%. Another thing to keep in mind is that this efficacy does drop with advancing age and with time as well. So that's why it really has fallen out of favor in terms of its recommendations. And here it already says it's only recommended if you can't access this recombinant zoster vaccine, which is the preferred one shown above. So if it's contraindicated, so you have some sort of severe allergic reaction to the first vaccine, or if it's simply unavailable or inaccessible, then consider the live zoster virus vaccine. So what about the administration of vaccines? So what's recommended by the Canadian Immunization Guide is you can get as many of these inactivated vaccines as you want at the same time. So in today's example, for example, you can get a influenza vaccine, since all the ones for older adults are all inactivated. Inactivated just means you can't get the disease from it. So you can't get influenza, you can't get pneumonia, you can't get shingles from any of these vaccines. So you can get, again, the influenza one with one of the pneumonia ones, because those ones you do need to space out, as I showed in the pneumonia section. And you can also get the zoster vaccine at the same time. it's preferred to get these vaccines in separate arms if possible, but you can also get it in the same arm, but space it by at least 2.5 centimeters if that's the case. And why that's important is what the clinician really is doing is they need to keep track of any possible allergic reactions. So they do have to write down which one do they inject higher in the arm and which one is the lower one that's spaced by 2.5 centimeters. So if there is any sort of allergic reaction, they know which vaccine it is. Another recommendation, because these can cause some adverse effects, so when it comes to the safety, most commonly it is pain. Of note, the shingles vaccine can cause quite a bit of other systemic side effects that are very well documented as well. So you may get those flu-like symptoms, for example. And the recommendation here is to receive the most painful injection last. So if you were to get more than one, you likely should get the recombinant zoster one as the last vaccine. And in the context of COVID-19, again, as I mentioned, right now is the time to really keep older adults healthy. So you want to get as many of these vaccines as possible. And typically you want to get it in one visit because you want to just, again, limit the contact points with these kind of settings because you're putting yourself at risk if there's other sick individuals around or if these sites do COVID-19 testing, for example, as well. And in terms of Saskatchewan, here are the vaccines I spoke about today and their availability. So when we're talking about the influenza vaccine, only the quadrivalent, again, is available for everyone, where the high dose one is only available in long-term cares and personal care homes, unless you can purchase it in a pharmacy. For the pneumococcal conjugate vaccine, this is the one with the 13. They do recommend it, but it's not available for free for adults 65 years of age and older. And for the pneumococcal polysaccharide vaccines, this is the 23 strain, older adults can actually receive one of these free of charge if they've never received a free dose from public health in Saskatchewan. But if they have, so if you happen to get it when you're under the age of 65, then it would no longer be free. And again, to reiterate, if you've never had one of these vaccines and you're interested in getting both, the preference is to get the conjugate, so the 13 strain one first, wait 8 weeks, and then get the polysaccharide one with 23 strains after. So in summary, what can we do to improve these immunization programs? Really, there's two things we can do. One is to increase these immunization rates. So as I showed you for influenza, for example, it's very, very low. If we're talking about pneumonia and shingles, those can definitely be better as well because of the limited access and coverage by public health can definitely be a barrier. But even when we talk about people getting the shingles vaccine, remember it's 2 doses. So even if it might be a little rough when you get the first one from the pain and the soreness, make sure you get the second dose as well to make sure you're fully protected. And the second thing that we can do to improve these immunization programs is to use these newer enhanced vaccines with this better efficacy or effectiveness. So thank you so much. I'm happy to take more questions now. And I'm just going to stop sharing now so I can look at the Q&A.
There is one question there, Gary, and I've got a list of other ones as well.
All right. So yeah, I noticed the first one again, which was presented before the presentation started, is which provinces do fund vaccines like high dose and Shingrix for adults over 65 years of age and older? So as I showed in the slide for the high dose influenza vaccine, it's available in long-term cares across Canada, but only in Ontario is it available for all 65 years of age and older. And for the Shingrix vaccine, to my knowledge, I don't think any province covers it. It's not part of my company's portfolio, so I could be wrong. But I think here in Ontario, they did offer the other vaccines, the live vaccine, for, I think, either 50 years of age and older or 65 plus as a one-time dose. But even if people in Ontario were to get that, it's still recommended to get the Shingrix vaccine.
Okay. Sure, I found interesting was how many similarities there were between COVID and flu, like particularly how much you can spread it before you have the symptoms. But I guess the good news is that a lot of the hygiene practices we've become used to since March for COVID stand us in good stead with avoiding flu as well.
Yeah, completely. Sorry, I noticed someone's asking for a screen. Oh, they want to take a screenshot of the flu vaccines. Is it this one in particular, or is it the Saskatchewan? What's available? I just want to clear. Sorry, just 1 second. So this is the one that's available, at least in Saskatchewan. But if you want, I can also send you a list of available influenza vaccines.
Thank you. So that's Mary that's asking the question. If that screenshot doesn't answer the question, then perhaps Mary could let us know. So, I'll just ask a couple of questions because we are kind of hitting 2 o'clock nearly. First one is, can I get all the shots at once? So you did cover that off, but could you get shingles, flu, and the pneumococcal all at once? If you had that slide.
Yeah, you can take all 3 of them at the same time. But what I was saying is, for since there's 2 different ones for pneumococcal disease, you have to pick one of the pneumococcal ones to get, and that in the end depends on what you've already received. But can you get one of each? Yes, you can.
So if someone hadn't had the pneumococcal, which one would they do first?
So if you've never received any of the pneumococcal vaccines, it's preferred or recommended to get the conjugate 13 strain one first, so that you only have to wait 8 weeks to get the polysaccharide one. The unfortunate thing is the 13 one is the one you have to pay for. If you happen to get the polysaccharide one first, so with the 23, then you have to wait 1 year before you get the conjugate 13 one. And also why I prefer to get the conjugate one is just how your immune system kind of responds to the vaccine, because it affects how well you can kind of boost the response. So if you get the polysaccharide ones, there's issues with boosting the response, whereas if you get the conjugate one, that's not an issue, which is why it's preferred to get that one first.
Would they give me the shots if I had a cold?
So if you have a cold, at the end, it will depend on the clinician. Usually, they will wait until you're 100% and better. Why some doctors or pharmacists may still give it is maybe you're already getting a little better. And these are also inactivated vaccines, so they can't cause disease. But why they'll wait is, if your immune system is busy fighting off already some sort of sickness, you may not get the best response, which is why a lot of the time I think clinicians will wait they'll wait until you're completely healthy before giving you any of these shots.
Right. Does the flu vaccine come out in the same month each year, or does it vary?
Sorry, can you repeat that?
Does the flu vaccine come out in the same month each year, or does the timing vary?
So usually it comes out around the same time, but sometimes there are delays. I think last year, for example, was a very weird kind of situation, because how flu vaccines work is we rely on a recommendation from the World Health Organization before companies around the world start making the vaccine. And so if the World Health Organization is a little late on what they recommend, it can delay everything. So last year in particular, flu vaccines came out a little later. But generally speaking, if we look across all the years, they usually come out in October. And that's been pretty consistent. And I think it will be the same for this year as well. So usually it's always at the same time.
How would I go about getting these vaccines? Do I have to go and see my doctor, or can I just go straight to the pharmacy?
Yeah, that's a really good question. So you can go to the pharmacies to get it as well, or you can get it from your family doctor. Probably what's recommended is to contact them ahead of time to give them a heads up so that they can be ready to vaccinate, all at once, or whichever vaccine you're interested in, so that they can actually have it ready and prepared for you.
Okay, so do you require a prescription from the family doctor?
If you were to get it at a pharmacy, what I suspect is you will need a prescription because these aren't covered by the universal influenza program. If we're talking about the high dose vaccine, for example. So likely if you want to get that in a pharmacy, you would need a doctor's prescription for it. And I think it's the same for the other vaccines as well, where you need a prescription from the doctor.
Okay. Will the vaccines interact with my medications?
So generally speaking, the vaccine will not have a direct effect on any of your medications, but of course that depends if you're receiving, for example, like biologic, for example. But really, if you want more details specifically, you definitely should speak with your pharmacist that can provide more details, because it depends on which medication it is. Because some medications do, for example, affect your antibody responses, especially for some biologics that some people receive for immune-related diseases. But generally speaking, people are a little more worried about bleeding risk, which is very, very minor, for example, if you're on a blood thinner, for example, and you happen to get one of these vaccines. But generally speaking, that's really depends on which medications you're getting. So you'd have to speak more with your pharmacist or doctor.
So there's a question in the Q&A saying, I was recently hospitalized with meningitis. Should I ensure I receive the pneumonia vaccines as soon as possible?
Absolutely. I think if you've had meningitis before, I'm sure you can understand how severe it is. And so if you're eligible for it, you should definitely get a pneumococcal vaccine to help prevent not just, to prevent these invasive pneumococcal diseases. And you'll get this added benefit as well if it's at least a conjugate vaccine, for example, that it can help prevent pneumonia as well.
Okay. So you talked about the increase of like side effects from flu, and one example was for up to 7 days after having influenza, the risk of heart attack increased. So if you have a flu vaccine, would it actually help you avoid the flu, or will it just reduce the severity?
So I think how a lot of people speak to the influenza vaccine is, for sure, it can prevent influenza. That varies from year to year on the vaccine effectiveness. But even if you were to get influenza, a lot of clinicians say it can attenuate disease, so it won't be as severe. But I can tell you the amount of information around that, I would personally say it's still unclear, but it's definitely a potential benefit and another reason to get it. Because if it does reduce severity, like you may still end up with getting flu because it's not a perfect vaccine, but you won't end up in the hospital, for example.
Okay. So this question is from Charles. He says, last year, 2019, some of our members planned and arranged to receive the high-dose influenza vaccine at their own expense because the province only provides them to seniors over 65 in long-term care. But there were no high-dose vaccines available in Saskatchewan in October, so people reluctantly settled for the low-dose vaccine. When high-dose finally became available in January and February 2020, we were advised by the health authority it was not advisable to get more than one vaccine per year. So the question is, if a COVID-19 vaccine is approved, produced and distributed in 2021, is it likely that people who received the usual seasonal vaccines would be advised to wait another half a year before taking the COVID vaccine?
So in regards to that question, so one thing I'll address with last year, definitely from what I know, I think the high dose vaccine was not available outside of long-term cares in Saskatchewan. And again, that's because there was a very weird kind of year where the World Health Organization was late on the recommendations. So there just wasn't enough supply. And so Canada didn't get enough doses to provide the private market if you wanted to purchase it out of pocket. But what we should keep in mind for the question is that flu vaccines, pneumonia vaccines, and when we do get a COVID-19 vaccine, these are all completely different and they're preventing different things. So again, I'm going to reiterate that the flu vaccine and also the pneumonia vaccine do not prevent COVID-19. But what they do is they will help keep you healthy so that you don't end up, at higher risk of COVID-19 if you were to get sick. And you generally want to protect yourself regardless so that you don't end up in a hospital or even getting tested for any sort of sickness, because again, you're kind of exposing yourself potentially to an area with COVID-19 exposure. So if the COVID-19 vaccine were to be available next year and you get the flu vaccine, you can, assuming it's an inactivated vaccine as well, you can also get the COVID-19 vaccine without having to wait. And another thing that I can address here is if you do happen to get one influenza vaccine, there is no evidence to show it's beneficial to get another one, which is why you're probably informed not to get the high dose vaccine later in the year. But again, the COVID-19 and flu vaccine are completely different. So you don't have to wait before getting the COVID-19 if it were to become available. Assuming there's no interactions that we're aware of, since there's no vaccine on the market yet for COVID-19, I can't give you any sort of guarantees, but if it's okay to get at the same time, there shouldn't be any sort of waiting due to getting a flu vaccine.
Okay. So the question is, when will high dose flu vaccines be available in Saskatchewan? And if they are, would they still be approximately $83 like last year?
In terms of the availability, I think it will be available at the same time as other influenza vaccines. Whether or not it's available in the private market, it may be, I'm not 100% sure since I'm from the medical team, so I'm not 100% on these supply related issues, but because of the high demand for flu vaccines as a whole around the entire world, it may again be challenging to get the high dose vaccine, but if it is available, it'll be at the same time as other influenza vaccines.
Okay, thank you very much. So the last question is, with COVID, we've heard different things like take vitamin D. With flu, you talked about make sure you stay hydrated. Are there any other suggestions for flu? Things you could do to make sure that if you do get it, you cope better? So perhaps, for example, taking vitamin C, or is that an old wives' tale?
So yeah, that's not proven for vitamin C. I know why a lot of people think that, because it can have, some sort of beneficial effect on your immune system. But from I know from scientific literature is vitamin C is only helpful at reducing the number of sick days if you get a cold that's triggered from cold temperatures. And you need to have been taking vitamin C for quite a bit of time in advance to even get that benefit. So if it comes to vitamin C and a cold caused by the virus, or if the flu caused by influenza, vitamin C won't have any sort of beneficial effect. So the most important thing is for sure to take care of yourself, to rest, stay hydrated. And if you are at very high risk for some of these more severe complications, is you can get a prescription if you see the doctor and they think it's appropriate to get an antiviral.
Okay. So this is the last question. You said the death rate from flu is the highest amongst vaccine available illnesses. So it's obviously disappointing. And if more people had it, took the vaccine, that would improve. So from your perspective as a practicing pharmacist in a community setting, what do you think is the biggest misconception that people have? Why do people not get their vaccines for flu?
That's a really, really good question. To be honest, I don't know if it's specifically a misconception. I know for sure there's a lot of myths around influenza vaccines. For example, whether or not they work, how safe they are, for example. But I wouldn't say it's a misconception in itself, but a lot of people are simply hesitant. So they just don't know, should they get it or should they not get it? And it can be often overwhelming, the amount of information you receive when it comes to vaccines, and that can cause quite a bit of confusion in itself. So I think it relies heavily on the clinician to really be very reassuring and say, hey, yes, it's recommended to get the vaccine, instead of just offloading a lot of information onto an individual and having them make the decision. So that's probably the bigger barrier to why people don't get vaccinated, because they're just wondering, should I or should I not? And then a clinician or pharmacist might say, well, this is what it can do for you, but in the end, it's up for you to decide. And in the end, they say, well, I don't know, so I'm not going to get it. But if I had to pick one, let's say, then I would say I think a lot of people think the influenza vaccine doesn't work, or influenza is not that serious. That's probably the bigger issue, where they think it's like the common cold. And I can tell you from my experience personally, at least, so maybe take it with a grain of salt if you want, since this is my own opinion and from my own experience. But when people have gotten influenza, I can tell you they know it for sure. If you've never gotten influenza, they'll come in for a recommendation and they won't know if it's the cold or the flu. But if people have gotten influenza, they know how severe it is. They'll say they felt like they got hit by a truck, for example. It's not even that, you should stay at home. If you get flu, you will be forced likely to stay at home because of how all the fatigue it's causing and the chills and the amount of discomfort. So another misconception is just how severe influenza is and can be, is another reason why people don't get the vaccine.
Thank you. So there's some questions about when will the vaccine be available, the high dose vaccine, and probably the best thing for us to do is when that's known, put it on the Facebook page or put it in the newsletter to answer those. So thank you to everyone for all the questions, and thanks to Gary for answering them. I'm going to hand over to Kathleen to wrap up.
Thanks for having me.
Well, thank you very much, Gary. That was extremely informative. I've heard several of these presentations, and it's amazing how much new information you can keep getting every time you hear this, and it scares the living daylights out of you to not get these immunizations. All the more reason for people to want to have these immunizations covered by Sask Health. I can address some of the questions with regards to availability and price. The high-dose flu vaccinations, the private ones, will be available at the same time as the regular dose flu vaccination, and that will be October 16th. The problem is where to find it. Because it'll only be available at select pharmacies. So once we've determined where that's going to be, we will certainly post that on our Facebook page and send it out in our members newsletter. As for the price, people may be wondering what the cost is because the government isn't presently paying for it. And the high dose flu vaccination is between $80 and $90 for a dose. The shingles vaccination, it's the two doses will run you between $300 and $400, and the pneumonia, the pneumococcal 13, will cost you approximately $100. So that's quite significant. You look at for one person, you look at a couple who are both over the age of 65, and that's substantial. So that is why we're pressing the government to our political parties as we head into our election this fall. to say whether or not they will cover these. We desperately need these to be covered because these are preventable diseases and will prevent deaths in the province. So that being said, I want to just a few comments. As we head into the election, please, if your candidates are calling on you, ask them about this and ask what they're going to do to help our older adults in Saskatchewan. And finally, if you're passionate about seniors issues, like to share your talent and energy to better our community, maybe you'd like some fun and camaraderie, which we do have here with our chapter, we invite you to join us. It doesn't matter where in Saskatchewan you're from, because we can now connect virtually. We invite people from all over the province to join us, join our chapter, and help us put on informational sessions such as this. So if you are interested, give us drop us a line, an email. Our email is carp@regina.ca. So I want to thank you, Gary, again for a wonderful presentation, very informative. Thank you everyone for joining us. I hope you have a wonderful week. Be well, be happy, and please stay safe. Bye now.